Welcome, everybody. This is our third meeting of the year. Tonight, we have the pleasure of listening to a close colleague of Dr. Hunt's and myself, Allison Tan, who is a member of the PAIRS board. She's speaking on a topic that's actually of a lot of interest of myself. It's not something that we're doing at Temple. Had a lot of resistance in getting it started. And I'm interested to hear how she's been able to transition it. I know a lot of you are familiar with her. Allison is a colleague of ours from Jefferson University. She's going to be speaking today on percutaneous Avf fistula creation, some of the trials and tribulations that they've been having with getting it up and running, and again, some of the outcomes that they've been having. The one thing that I did want to remind everybody is if you have questions, just type them into the Q&A session. We'll go over them at the end. And then I'll let Allison kind of speak to this slide as well as she starts her presentation.
Great, thank you so much. I'm so happy to be here tonight and talk to you about this topic. It's something that I've been focusing a lot on and learning a lot about over the last about a little over a year. So again, I'm Allison Tan. I'm an assistant professor at Thomas Jefferson here in Philadelphia. So my first slide here, I just want to extend a warm welcome and congratulations to the 2021 PAIRS Resident Fellow Board. So just want to go through the names and introduce all of these folks to you. We have Akash Desai and Zaki Naveed from Einstein, Josh Kornblum from Christiana, Shuja Hussain from Mainline Health, Stefan Lung from Jefferson, Ankit Molla from Cooper, and Rupal Parikh from UPenn. So these folks are certainly going to help us run a bit more smoothly with communication and preparation for each month's meeting. And hopefully we'll be contributing a great amount of insight to growth and development of PAIRS as a whole. So please welcome them, and you'll hopefully be seeing and hearing more from them throughout the year. So tonight I'm going to talk to you about percutaneous AVF, but I said percutaneous AVF enters stage right just because there's so many other players on the dialysis stage that we can't just look at percutaneous AVF in isolation. So we're going to talk about all the other players as well, at least briefly. My financial disclosure is that I am a consultant for Becton Dickinson, which is the company that makes Wavelength. I joined their team about 9 months after starting Jefferson's endo-AVF program here. So I'm going to talk a lot about procedural innovation, techniques, and data, but ultimately our goal is to help our patients. We want to provide them with good dialysis access and better options to help them live longer with ideally a good quality of life. And that's what this is all about. So I'd just like to start here to help us remember that. So the US Renal Data System compiles information annually about the state of renal disease in the United States. It's funded by the National Institute of Diabetes and Digestive and Kidney Disease. Information is compiled from the Centers for Medicare and Medicaid Services in the United and UNOS and ESRD networks. So looking at their data and the incidence of ESRD, end-stage renal disease, how many new cases are diagnosed each year, you see that the incidence has actually plateaued since the late 90s. Zoom in here. But when you start looking at the prevalence of end-stage renal disease, that's how many total people are living with ESRD. Instead of plateauing with the incidence, the number of people continues to rise. So patients are living longer with end-stage renal disease than they ever were before, with over 745,000 people in the United States living with end-stage renal disease, and 8,500 people in Philadelphia alone. So how are we prolonging the life of someone with kidney failure? And we use renal replacement therapies. So just to put fistulas and grafts in context, I just want to briefly review all the renal replacement therapies that we have. So this picture up here is an artificial kidney. So until we can reach that, wonderful moment when we can employ an artificial kidney in clinical practice, we have renal replacement therapies. And transplant is certainly the most ideal modality for renal replacement therapy. And currently in the United States, transplant is the second most common modality for renal replacement therapy. And if you look at the percentage of patients who are receiving transplants, you'll see that the younger population is more likely to receive a transplant and that makes sense. We're promoting survival of patients who are likely to benefit the most. So what about patients who don't get transplants? Well, those patients require dialysis. And something we don't talk about very much is peritoneal dialysis. Peritoneal dialysis is an excellent option for patients who want to maintain a high quality of life, a high level of activity. This method of renal replacement therapy is performed every day from home, often while patients are asleep. So they instill dialysate into their abdomen, and at nighttime, that dialysate cycles through a machine. So patients can even travel on peritoneal dialysis and have their dialysate shipped to their destination. But unfortunately, in the United States, peritoneal dialysis is the least commonly used form of renal replacement therapy. I think we'll start to see an increase over time with changes in reimbursement for PD, but currently it's still, we're pretty dismal about using this method of renal replacement therapy. But similar to transplant, you see patients in the youngest age groups on PD more commonly. So moving on to hemodialysis as a renal replacement therapy. So of all the RRTs, hemodialysis remains by far the most common modality used in the United States. And contrary to transplant and PD, the percentage of people using hemodialysis increases as the patient age increases. And there are multiple ways in which patients can receive hemodialysis, and catheter-based is incredibly common. So 80% of patients starting hemodialysis will initiate on a catheter. And this has remained relatively stable over the past decade. Note that this graph includes patients with alternate access options that are also not ready for use. So catheter-based hemodialysis has some issues associated with it. I mean, the benefits are that it can be done quickly. The catheter can be placed and used the same day, tends to be pretty reliable, and it can come out if the patient, for some reason, doesn't need dialysis anymore. But the negatives are patients have a significant increase in morbidity and mortality, including infection, hospitalizations, and death. So over time, if you look at the percent of patients on catheter-based dialysis, you see that that percent decreases up to about 2 years. And those patients with surgical access actually increases, with about 70% being transitioned to fistula use after 2 years. So, however, if you include all comers, including patients that drop out due to death, you see that the number of patients using a fistula graft actually plateaus after about 9 months. And the changes we saw in the prior slide are more a result of a decrease in the denominator due to patient death. Okay. So catheter use, again, high morbidity and mortality. So in 2006, the introduction of the Fistula First Breakthrough Initiative, it was called Fistula First, Catheter Last. There's been a push to increase AV fistula use and decrease catheter use, setting a goal of 66% prevalent AV fistula use for hemodialysis. So AV fistulas were chosen as the ideal access for reasons listed here, including lower morbidity and mortality, better primary patency, lower infection risk, and need for fewer interventions. So I want to look at fistulas and grafts together. That's kind of what we're going to be talking about, but really we're just going to be focusing on fistulas tonight. Just for some of our younger trainees joining us tonight, a reminder that a fistula is a communication between a person's own artery and vein, while a graft is creating that communication with a synthetic tube. Okay. So this is a good example of how graft material differs from native vein and ultrasound, and it's important to know as a physician who might be doing interventions, because histories are typically very poor and oftentimes they're referred to as fistulas, no matter what the modality is, the method is. So here's a PTFE graft, and you can see that double white line of the wall compared to a native vein, which has an imperceptible wall. So let's look at surgical access. It's probably been a while, but there's issues, surgical access we talked about being, the best modality currently for hemodialysis access and what our ultimate goal is, but it's not without issue. One of the biggest issues is the absence of pre-dialysis care for patients initiating dialysis. So USRDS shows a 34.5%, that's more than a third of patients starting dialysis for the first time had zero pre-dialysis care. They never saw a physician to discuss their renal dysfunction. And that's a huge problem because surgical and percutaneous AV fistula creation requires time, planning, and maturation. Minimum of 6 weeks if an access site matures primarily. However, many access sites will require longer to mature. So this is not a problem that will be fixed by percutaneous AVF, as you'll see, but it's something that we have to keep in mind. So hemodialysis has access has incredibly variable reported maturation rates. So just some sample studies, Denver et al. 2008 JAMA paper showed that during their study looking at the effect of Plavix on primary fistula patency, they found that 60% of fistulas in their study failed to mature. And they actually terminated that study early. Observational cohort study by Woodside saw that 54.7% of fistulas were not used within 4 months of creation. Now there's a lot that can be responsible for that since they were looking at CMS data, but it gives us an idea of how many of these fistulas are progressing to use. And the hemodialysis fistula maturation study looked at over 600 AV fistulas and found that only 43% of them actually matured without any additional intervention, and 22% of them failed to mature completely. So looking a little bit more closely at what could be causing these variable maturation rates. So it's possible that as we push to, with the Fistula First initiative, push to put more fistulas in dialysis patients, we are possibly relaxing our criteria for candidate patients and creating fistulas in patients who are maybe not the best possible candidates, leading to a lower success rate. Additionally, going back to our graph of the increasing prevalence of renal disease in the population, these patients are living longer. And as patients age, their vasculature ages with them, their comorbid diseases progress, all potentially contributing to a less ideal surgical candidate and higher failure rates. Finally, there are multiple technical factors that have been evaluated and hypothesized to be causing fistula dysfunction. So let's take a look at these technical factors in a little bit more detail. So this is AV fistula creation done by Nahel Elias, who is the director of kidney transplant at Mass General Hospital. So just to remind us, for many people, it's probably been a long time since you've been in the operating room and seen a fistula being created. And it's just a reminder of what happened. So that here they've isolated the vein and they are going to anastomose it to the radial artery. This is a radiocephalic fistula. Okay. So when we're creating a fistula, there's a couple things that need to happen. We need to isolate that vein, as you saw. And there are these things called the vasa vasorum, which in Latin translates to the vessels of the vessels. And literally they're important blood supply to the walls of the arteries and veins. And if you remember this, or were able to catch this part of the video, you can see that they're skeletonizing the vein and disrupting the vasa vasorum, resulting in a degree of vascular wall ischemia that can compromise healing and lead to vessel scarring and stenosis. Additionally, when we move the course of the vessels, we create torque and tension, and it alters the natural course of the vessel. This can lead to turbulence of blood flow, subsequently endothelial damage, and potentially intimal hyperplasia and stenosis. And finally, suturing the vein to the artery results in a need for this anastomosis to heal. And healing naturally occurs with scarring, which can also cause stenosis and poor fistula function. So aside from technical factors and variable maturation rates, moving on to access site limitations. And so let's look at the sites that are available for AV fistula and graft placement. So fistulas, and this is a very simplified version, I understand that, but I want to make a point that we do have a limited supply, a limited number of locations in which we can do these procedures. So if you count the places that you can do fistulas at the wrist or in the upper arm, and grafts in the upper arm and in the groin, we have about 6 sites, okay? But it may seem like a lot, but if you start to remember that 80% of patients will initiate on a catheter, or the variable maturation rates of the fistula and the surgical procedures cause a need for prolonged catheter use, a long-term indwelling catheter can cause clinically significant central stenosis and result in that entire upper extremity not being usable for surgical access, or at least straightforward surgical access. So you significantly decreased your access site options just by catheter use. Okay. So I know I'm moving kind of quickly, but I want to get a chance to talk a little bit more about what we're here to talk about today. And that's percutaneous AV fistula creation. So this is the first major advancement in hemodialysis access in 50 years. It's incredibly different than what we've been doing so far. And so in 1966, the Brescia-Semino radiocephalic AV fistula was first reported. And since then, we've been using the same surgical techniques to do this procedure in different parts of the body. So percutaneous AVF does something different. And in trying to mitigate those technical factors that we talked about before, how can we remove them from the picture? And efforts to develop new methods for fistula creation drew from the observation that traumatic fistulas, those that occurred between arteries and veins that already ran adjacent to each other, were incredibly durable and often required surgical correction for closure. So traumatic AV fistulas can go undiagnosed for many years, resulting in significant venous dilatation and tortuosity of the outflow veins. So on the right, you have an image of it in a more acute AV fistula. So you see arterial flow and then immediate filling of the vein. And if this is left untreated over time, you get bulbous enlargement of the outflow vein and the fistula remains. It doesn't shut down automatically on its own. So the new percutaneous endovascular devices, AVF devices, strive to reproduce the environment that makes traumatic fistulas so durable. By doing this and creating it between arteries and veins that already run adjacent, we're not disrupting the normal anatomical course of the vessels or surrounding soft tissues, and we're not requiring a suturing of an anastomosis to result in scarring. So let's go through the anatomy in the upper arm that allows this, these devices to work. So I'm going to start by introducing the arteries. You have the brachial artery, it divides into the radial, the ulnar. I call this the common ulnar, which then divides into the ulnar and the interosseous. So in the deep veins in the arm, they tend to run with the arteries. So the same name, paired vein with the artery, but not only one paired vein runs with the deep arteries, the deep vein system, but you have two veins. Okay. And it's this location in the deep veins and the artery, it's paired artery, is where we're going to create the percutaneous AVFs. So let's layer on the superficial system, because the superficial system, venous system, is where we're actually going to need to access for hemodialysis. So if we create a fistula in the deep venous system, we need some way for the blood to get to the superficial system and for that flow to develop there for successful dialysis access. So that's where this guy comes into play. So this is the perforator vein. And the deep and superficial venous systems have lots of perforating veins. We think about them all the time in the lower extremity veins with venous insufficiency and reflux and perforators. But there's one specific perforating vein in the antecubital fossa that is essential for both ellipsis and wavelength, which are the two percutaneous AV fistula devices, to work successfully. So this perforating in the antecubital connects the deep veins in the forearm with the outflow cephalic vein and the superficial basilic vein, which would be used for dialysis cannulation. Okay. So when we look at for a perforator on ultrasound, it's been referred to as a setting sun. So I love this slide. It makes me feel very calm. But what you're going to see is a cephalic vein joining with the median cubital, and those the superficial system, and this perforator vein dropping down slowly into the arm, and it will join with the radial veins and the deep ulnar veins in the arm. And when you see that, you know that there's a potential for the blood flow in the deep venous system to reach the superficial system. So who is a candidate for percutaneous AVF? Well, as I've just harped upon, you have to have a perforator vein. If you have no communication in that location, you can create a fistula, that's well and fine, but you'll never get the blood where you need it to go. You have to have no history of upper arm AV fistula creation. You don't want to have that anatomy disrupted, which will limit your ability to have the appropriate blood flow and venous maturation. You don't want any flow limiting central stenosis. If it's not flow limiting, you can, make that decision on a case by case basis. You want the vessel size at the target creation site in both the artery and vein to be greater than or equal to 2 millimeters. And ideally, you'd love your outflow veins to be greater than 2.5 at most locations to hopefully encourage maturation. You don't want to have any significant arterial calcification. So arterial calcification can limit the abilities of the devices to do what they want to do, which is make a communication between the artery and vein. So you can imagine it's kind of bumping up against a brick wall. As we get more comfortable with these devices, we see that we can be a little bit more flexible with that requirement and sometimes hammer away at it. Conscious sedation candidate, it's much more ideal if a patient can undergo conscious sedation and or anesthesia, although there have been cases that have been done under local anesthesia or a nerve block, and those patients have done fine. Okay, so I want to go back to no prior upper arm AVF creation or surgical fistula access, surgical dialysis access. So this is really important as it highlights the need for a multidisciplinary approach to these patients. So once a more central access site is created, the use of the peripheral sites is generally no longer possible. So depending on who's doing this procedure, whether it's vascular surgery or interventional nephrology or interventional radiology, you always want to be communicating back and forth, because if a surgeon does a radiocephalic and then they go right to the upper arm, they've kind of ruined your options for percutaneous access in the forearm. So you always want to be communicating about what the patient is a candidate for well in advance, so that everybody knows what the algorithm is for each individual patient. So although we're not able to change the issues around pre-dialysis care as we talked about, percutaneous AVFs can address some of the other issues. And we talked about a little bit about why they might remove some of the technical factors. But when we go back to this picture about access site options, we see that percutaneous AVF uses a novel access site in the forearm for creation that's not typically used for surgery. So by doing this, we're expanding the number of options patients have for access site creation. And as patients quickly and rapidly lose access options, these extra sites can really be crucial to keeping them on dialysis and off via an access site other than a catheter. So let's go into the two endo-AVF devices on the market. They're named Wavelength and Ellipsis, and Wavelength initially was called Everlink, so you may see that in the literature as well. So I'm going to first review the Ellipsis vascular access system. This is the device, and it's a single device, and it's done completely under ultrasound guidance. It's a 6 French system that creates a communication between the perforating vein and the proximal radial artery. So this is the area that we're looking, this perforating vein and the proximal radial artery coming off here. So this video is about 1 minute long, and it's going to show you the basic steps for, let's see if I can go back, it'll work, okay, of the procedure. And then we'll go into more real life images, videos of the procedure. So this is the needle tracking down the perforating vein. It's passed through and through the vein into the proximal radial artery. Through that needle, a wire is placed, and the needle's exchanged for a vascular sheath. So that sheath goes through the vein and into the artery. So again, you have through and through access. The Ellipsis device is introduced. Okay. And the tip of the device is in the artery, and the backstop of the device is in the vein. And once you get that position, you close the device, heat is applied, and the fistula is created. Okay. All right. So I don't have the ellipsis device here at Jefferson, hopefully yet. So I can't show you pictures from my own procedures. But this is Alexandros Malios. He's a French vascular surgeon. And he has a couple of videos online that show him doing a procedure in real time. And actually the Ellipsis Wave site has multiple live procedure videos that you can watch if you want to go and investigate more. So in the first step, he confirms his anatomy. And I'll just play that again. So here's the perforating vein as it drops down into the arm. And here it's going to abut the proximal radial artery as just beyond the bifurcation. This would be the ulnar and this would be the proximal radial artery. So this is the target site that he's going to be approaching. So in this clip, he's accessed the perforator vein, or I think he actually accessed the peripheral cephalic, upper arm cephalic, and he's millimeter by millimeter marching the needle down the perforator vein. So for most people, they report that this is the steepest learning curve is the ultrasound technique needed to guide the needle down the perforator vein without hitting any of the walls or getting outside of the vessel. Once he gets to the proximal radial artery, he angles the needle a little bit, advances it into the proximal radial artery. So here you're going to see it popping into the radial artery. And he gets confirmation with backflow of arterialized blood. And under ultrasound, he's watching as a wire is passed into the proximal radial artery. So that wire, the sheath is placed over the wire and the device is introduced. And you can see that he's meeting some resistance, almost like if you were withdrawing a tip stent. He's closed the device, pinning the arterial and venous walls together and applying thermal energy. And you can see the bubbling from the activation. Afterwards, the device is removed and there's immediate tissue fusion. This is what a gross specimen of that anastomosis would look like, that tissue fusion. And you can see the charring from the heat activation that's created that fusion. They found over time, over the initial study periods, that there was such a need for balloon angioplasty early in the post-procedure period that now balloon angioplasty to 5 millimeters is done immediately at the incident procedure. Okay, so that's the gist of ellipsis. Once a proceduralist gets good at the procedure, it can take 25, 30 minutes. It's a very quick procedure, no fluoros needed, and we'll kind of review this again at the end. So let's look at the wavelength device. Okay. So in contrast to ellipsis, which creates the AV fistula at one location, we talked about the perforator vein with the proximal radial artery. Wavelength device has the option to create it in 2 locations. So again, in the proximal radial artery and vein, and then also in the proximal ulnar artery and vein. In order to do that, it requires needle access to both the artery and the vein. So this is a 2-site access. So arterial access options, arterial and venous access options include the brachial artery and brachial vein in the upper arm. And although it's off-label, you can get arterial access at the wrist, but venous access at the wrist is FDA approved. So your site selection depends not only on the diameter of the vessels being appropriate for access, but also as well as your planned creation site based on pre-procedure mapping. So for example, if you were planning on creating a fistula in the ulnar artery and vein, you're not going to access the radial artery and vein at the wrist. You just won't be able to position those catheters appropriately. So the procedure begins by obtaining sheath access. In this example, they're coming from the brachial artery and lateral brachial vein. If you're coming from the brachial vein, you need to navigate retrograde through the vein to get to your target creation site. And so that'll be against valves. Whereas if you're coming from the wrist, you don't have to worry about the valves. And you can, and just a point of clarification, come anti-parallel. So one can come from the wrist and one can come from the upper arm if need be. So once you get arterial and venous access, you've navigated to your sites, you're going to introduce the components. So this is the components of the Wavelength device. This is the venous, I'll call it an electrode, and that has the radiofrequency hump. And in the artery is the electrode with the ceramic backstop. And so the energy is going to be transmitted from the vein to the artery. So introducing these components, you're going to watch for them to oppose with each other. The radiodense areas are little magnets that draw the two components together and bring the artery and vein in proximity to each other. This is what that looks like in a little bit more of a clear image. Once you get in line, you're going to do something called the catheter walk. And I've kind of posted about this on social media. It can be a little tricky, but what you're looking for is to make sure that the components are properly aligned. Here we have a saying that's called "one view is no view." So it's possible that you have the catheters, the electrodes a little bit askew, and that they look like they're lined up, but they're not actually lined up. So when you catheter walk like this, you're going to see the venous electrode deflect, showing you that it really is in line with the arterial foot plate. Once you have that confirmation, you're in the right position, you're ready to create. So you're going to see the arm jump a little bit, and that actually is probably the biggest indicator that you've activated the device. And that's more muscle spasm than discomfort. The patient doesn't actually feel discomfort. But if you look closely, you'll see this venous electrode jump across to the arterial. Okay. And we usually like to save this to just review it, because if your catheter electrodes are too far apart, you'll see that they don't actually meet each other. And that's going to be a little concerning. And I've said it before that if you're looking at yourself wondering or thinking to yourself, I'm not sure, then it's possible that they haven't met. And that's usually more what you realize. But either way, you're going to confirm it with a little injection from the arterial sheath. So here in this image, we've injected the artery, and just very lightly, you're seeing veins filling. And that just confirms for you that you have a successful creation. So you'll remove your venous electrode followed by your arterial electrode. And similar to how the ellipsis requires balloon angioplasty immediately after, Wavelength requires coil embolization of the brachial vein immediately after, because in the initial trial patients, they've found that a significant number of patients were needing to come back for coil embolization. So doing this at the incident procedure encourages flow to track superficial by blocking off one of the deep outflow options. Oftentimes, this doesn't occlude or thrombose that brachial vein because of all the communicating veins between the two deep brachials. So you can still have good patency of that vein if you need it in the future. Okay. And so this is the ultimate goal here. So just to review the post-procedure anatomy for a wavelength, because it can be pretty confusing. And this would probably be what you see, this would be what you'd see with an ellipsis if you were doing fluoroscopy, if you had to go back and do an intervention later on that needs fluoroscopy. This anatomy will be similar, just with the radial artery and vein. So for example, if we created in the common ulnar artery and vein, this would be pre-procedure, your venous injection. You see all the communications there are in the antecubital fossa with the perforator vein coming here and the outflow into the cephalic and the basilic. Your arterial injection shows a nice clean artery, the inner os, the ulnar, the radial. Post-creation, this is what you'd expect to see. So oftentimes in the beginning, when you're looking at these things, you say, if it looks a mess, then you've been successful. So if you inject the artery, and this example is different from the one just right before, but the artery is coming from the brachial artery. There's an anastomosis. which is your endo-AVF, your percutaneous AVF, and then filling of the perforator vein out the cephalic and the basilic. You also see filling of that other deep brachial vein. And this is just post-coil embolization. So an endothelialized tract forms in about 30 days. And this is the gross specimen of that. You notice that here there's an absence of charring. So the radiofrequency doesn't really cause a lot of heat damage or much heat damage at all to the tissues. So you're not going to see the scarring required for healing as you do with ellipsis. It just forms a clean endothelialized channel. Okay. So when looking at both wavelength and ellipsis, this is all you're going to see on the skin afterwards. This would be wavelength with a dual access. Ellipsis, you'd have a little mark right in the antecubital. Okay. So just comparing the two together as well as to surgery, we've already viewed ellipsis as a single, wavelength is a dual, surgery, no vascular access, surgical incision. Ellipsis is a thermal resistance, wavelength is radiofrequency. Ellipsis is purely ultrasound guided and wavelength is fluoroscopic guided. Tissue fusion occurs with the ellipsis, whereas the precise slit in the tissues without really much tissue fusion at all is through the wavelength. And the blood tends to flow by path of least resistance. So you're not going to get a lot of spillage into the surrounding soft tissues because you haven't disrupted those soft tissues. Those supportive tissues are still intact. The biggest difference, I think, is really the fluoroscopy and the single and dual site access, and often the time of the procedure, but we can talk a little bit about that. Oops, sorry about that. So on post-procedure ultrasound, I mean, these are the guidelines I kind of look for on my patients. The classic that you'll see in the literature is 6, 6, and 6. So a 6 millimeter vessel for cannulation. That's 6 millimeters or less from the skin with a flow volume of greater than 600. These fistulas are often a little bit lower in their flow volumes, and that actually works in the patient's favor a lot of time. There's a lot less turbulent flow, which decreases the rates of intimal hyperplasia and endovascular damage and trauma, endothelial trauma. There's that lower pressure and lower flow volumes will hopefully help prevent aneurysm formation and growth, especially if you're diligent about needle access site rotation. I have found that 6 millimeters of depth is probably too much. People struggle with 5 millimeters of depth, even with larger vessels. So something to keep in mind, but just as long as you have maturation requirements. And they tend to be similar to surgical AVFs. Okay, so there's the diameter, the depth. And then this is just an ultrasound of what you'll see. So here's the perforator vein coming down. This was an ulnar creation. And you see this bulbous area here, that's your fistula. Okay. So I'll just play it again. Focus your attention on the ulnars. You see 1, 2, 3, 1, 2, 3. Oh, it gets really big right there. And so it may look like a bubble in the vessel or an aneurysm of the vessel, but that's a nice, widely patent fistula. Okay. And this is what we'd love to see, of course. So in an appropriate patient with a good BMI, great outflow vessels, this patient has split outflow. You see outflow through the median cubital up into the basilic and a beautiful cephalic right here. So one of the trial studies, the NEAT trial, which we'll touch on in a moment, looked at the sites of cannulation for which patients were typically more likely to mature, and found that 58% were cephalic, 26% basilic, and about 16% of patients actually had split flow through both the basilic and the cephalic, which opens up some options for cannulation if the flow volumes are good in both. So does it work? That's the ultimate question. And you probably know the answer is yes, because you're seeing this done more and more. People are buzzing about it or talking about it today. So we see that it certainly can work. And this is just compiling all, the early data from the two devices, just for ease of comparison. I know it's a really busy slide, but it's nice to just be able to look at across studies, how they're comparing to each other. So the dark red rows at the bottom are ellipsis device papers, and the top half are wavelength device. So the NEAT trial was the 2017 trial, which really was kind of the first trial that brought it out into the population, whereas Rajan trial was more of the proof of concept and safety trial. But you saw that technical success across both devices is incredibly high, a 97 to 100%. And maturation at 90 days is also very high. So the lowest being 86%, and that's maturation by ultrasound criteria, up to 100% maturation in 105 ellipsis patients. Median time to maturation, 58 days, 63 days. Interestingly, one ellipsis patient had maturation of their fistula by ultrasound criteria at 10 days. So that anastomosis is open and flowing very early on. And you're more likely to see earlier maturation in patients who've had, for example, like a radiocephalic fistula with already dilated upper arm veins. Patency rates, primary and cumulative patencies listed here, 6 months. The papers are obviously not in line with each other always, so I just listed them the best that I can. But primary patencies, I mean, the lowest here is 69% at 12 months, as going all the way up to 92.7% cumulative patency for an ellipsis study at 24 months, which is significant. But and then use for dialysis sessions. We kind of, in the dialysis world, they classify a functioning fistula or surgical access if it's able to be used for greater than 75% of sessions for dialysis. So it doesn't even have to work perfectly 100% of the time, just greater than 75% of the time. Reintervention rates were pretty low for each, and especially they dropped down once they started doing those interventions at the incident procedure. So the balloon angioplasty and the coil embolization of the brachial vein. And adverse events, most of them are earlier on were related to, the big ones were related to access to the brachial artery and attempting to use closure devices, even though that was off trial, off label there. But generally now in my patient population, the most common complication I see is bruising, is ecchymosis. So hematoma formation, accessing the radial artery. We try to get away with a radial band a lot of time, but a lot of my access is ulnar, and I just find that the radial band doesn't work as well in the ulnar artery. Okay. So I just took some of this data and in order to be able to include surgical AV fistula data, because that's really one of the big questions is how does this compare to surgical fistula creation? So technical success is right up there with surgical fistula creation. And 90-day maturation. So we've talked about how all over the board the results are for surgical fistula maturation, 40 to 80%, and percutaneous fistulas are falling well within that toward the higher end. Median time to maturation, 159 days. The earlier studies were seeing much less than that. And cumulative and primary patencies were also on par. So reintervention rate, surgical AVFs tend to be 1.5 to 3.3 interventions per person year. And the earlier studies were showing much lower reintervention rates required for ellipsis and wavelength devices. So looking at some of the meta-analysis papers, which compiled 300 patients looking at wavelength versus ellipsis, you see that they compare pretty well to each other. Technical success rates are incredibly high. 90-day maturation, just shy of 90%, with 6-month patencies in the 85 to 90% rate. And the adverse event rates were lower. The higher adverse events rates in the wavelength were again mentioned due to some of the brachial artery access issues with closure devices. So that's showing that they compare very well to each other. In terms of comparison to surgical fistulas, so Instant did a paper looking at radiocephalic surgical AVFs compared to wavelength only, and just looking at the outcomes, and they found that wavelength outcomes were correlated very well with radiocephalic fistula creation, with slightly better secondary patency rates and primary patency rates at 6 months and 12 months. Cost comparison, looking at CMS data, and this is again from some of the earlier studies, found that there was a reduction in cost related to percutaneous AVF devices, primarily due to the lower need for reintervention. And that was just looking at CMS data. So that's some of the initial data. That's kind of pooling all the initial data, comparing one device to the other, comparing one device to surgical fistula creation, and then looking at costs and making sure the cost comparison is appropriate. So let's look a little bit at real world usage, because the earlier papers being very selective in who they're choosing for this procedure, they training their physicians to use it. So we want to know how this device is functioning in the real world. So Zamella looked at 35 Wavelength patients and found that their technical success was 100%. Most of their fistulas were ulnar to ulnar, and 41% required secondary procedures. So that's up there with surgical fistula creation. 48% had usable percutaneous AVS at 73 days, and that included patients who were pre-dialysis and also using the fistula. And patency rate was really high at 88% at 160 days. So for Wavelength procedures, their secondary procedures were predominantly a branch vein coiling, so needing additional flow diversion to help mature the superficial outflow with lower rates of PTA and thrombectomy. So Sultan looked at ellipsis patients and found that 46% had mature fistulas or were using them for dialysis at the end of their 6-month period, with some of those patients of that 46% not still pre-dialysis, but mature based on ultrasound criteria. And that 66%, almost 67% needed additional procedures. So that's much higher than the initial data suggested. And for ellipsis patients, the majority of those secondary procedures were angioplasty of the anastomosis. So restenosis, likely related to that thermal injury and restenosis after that. So I like this data. This is data that was presented at Kidney Week 2020, because this is a unique physician. He's an interventional nephrologist in Texas who uses both ellipsis and Wavelength. So he's able to compare within his own practice and remove like operator variability and outpatient follow-up variables from that equation. So he looked at his data looking at ellipsis and Wavelength. He did primarily ellipsis. At 12 months, after 12 months, he'd done 126 successful creations with a mean time of maturation 101 days. So a little bit longer, about almost twice as long as what we were seeing in the initial papers. Only had 21% failure, so that's 80% success rate. With failures more common with the radial Wavelength, secondarily ellipsis, and then the most successful procedures were the ulnar Wavelengths. And additionally, women were more likely to fail creation than men. And this is seen with surgical fistulas as well. Something about their vasculature is just not as compliant and the flows don't pick up as much. He found that higher brachial artery flow rates correlated to better maturation and better success, and that those higher brachial artery flows were seen with ulnar creations. And his mean number of secondary interventions in his own practice were similar between the two devices. Okay. So there are certainly areas, I mean, just looking at the difference between the initial data and the real world usage, there are definitely areas that require focused improvement. So I've already kind of stressed on the need for a multidisciplinary approach for these patients. Just like oncology patients, these patients would benefit tremendously from better communication amongst their dialysis centers, their nephrologists, their primary care physicians, and their interventionalists, and plus or minus surgeons, depending on who's doing all of these procedures. It would expedite their patient care, and as well as any interventions that were required. And additionally, not an insignificant number of dialysis patients are not the best at follow-up, so having better communication between all their care providers could help encourage better follow-up in these patients. So as mentioned in Sultan's paper, we know that many pulmonary percutaneous AVF patients, just like surgical fistula patients, require subsequent interventions. So planning for that early will help speed up maturation times. Instead of seeing them in clinic, seeing that they need an intervention, and then scheduling them for that intervention, you can lose weeks in that process and potentially lose the patient to follow-up. So possibly scheduling the patient for follow-up with a planned intervention and canceling if necessary might help expedite things. And one really important area for QI is cannulation support and improvement. So percutaneous AVFs have really revealed how much room there is for improvement in the dialysis centers and their cannulation abilities. So things that interventionalists think are routine, like ultrasound guided access, are not routine in the dialysis centers, and using those could drastically improve cannulation success. And so by focusing educational and support efforts in the side of fistula use, we could see significantly improved durability and patency of both percutaneous and surgical fistulas. So overall, what are the deep thoughts? Percutaneous AVF technology is incredible, and ellipsis has the benefit of being single site access, a quick procedure, no fluoro, and not as many supplies as needed for wavelength. It's a great procedure for an OBL or ASC centers. And secondary, the downside is secondary procedures for ellipsis tend to involve more PTA and combating arteriovenous stenosis and thrombosis. Wavelength has the ability to create in 2 different locations versus the one, the ellipsis, which could bring in more candidates than just ellipsis alone. And that extra location being the ulnar location, which is proving more durable with less issues post-procedure in some practices. In my personal practice, the majority of patients have ulnar arteries and veins that are at least double in size their proximal radial artery and veins. So a quick, straightforward wavelength can be the same length as an ellipsis. It can be 25, 30 minutes, but sometimes they're longer and they require more room time. Additionally, the outcomes, although promising in initial studies to be better than surgical fistulas, are at least looking more on par with surgical fistulas. So I don't think this is a bad thing, because if you remember our discussion about limited access site locations for dialysis patients, what I think the greatest benefit of percutaneous AVF is the increase in options they provide. So let's just quickly, fabricate the ideal access candidate with beautiful vessels that are perfect for all options. So you could do a radiocephalic fistula first, and if that fails and the artery is still intact, you could do an ulnar basilic. And if that doesn't work, you could do a wavelength proximal radial. If that doesn't work, you could do a wavelength ulnar radial, ulnar. If that doesn't work and your perforator and artery is still intact, you could do an ellipsis in the more proximal radial artery. And then if that doesn't work, then you can go to the upper arm surgical options. So that's 3 additional options in the forearm that you could potentially have for a patient to help prolong their use of surgical or procedural, percutaneous fistula use, and keep them off a catheter. So finally, thinking outside of the box. So clearly its use for dialysis access creation is right up there, and that's what we're focusing on. But over time, we're going to start to think about different uses for this device. Creating fistulas for patients that potentially need more oxygenated blood return to the heart, or creating fistulas in places where we need more blood flow, either for improved wound healing or improved flow for venous stent patency. I think we're going to see and start coming up with really creative uses for these devices. So bringing us back to where we started, we remember why we push in medicine with things like percutaneous AVF devices. Improving duration and quality of life for patients is the ultimate goal. If we can improve pre-dialysis patient capture and care, establish a comprehensive multi-D approach to renal replacement planning and dialysis access and initiation, foster patient education and ownership of their disease, and continue to fine-tune the technologies being introduced in the clinical realm, we'll make great strides in accomplishing our goal. So I know that ran a little long, but thanks so much, and I'm happy to answer any questions.
Thanks, Allison. That was great. There were a few questions that came in. One was basically on the pre-procedural evaluation. So Are you doing any sort of like mapping venograms, whether it be with ultrasound? Like if this patient comes to you, are you sending them to ultrasound for any mapping venograms? Are you doing contrast venograms? What's your pre-procedure about?
So the very earliest trial patients were getting venograms. So peripheral IVs placed, and they were looking at the venous vasculature. We all now do our screening with ultrasound, and this can actually segue me a little bit into practice management and practice establishment, because that's where all your mapping should occur. I didn't have a chance to go into it too much tonight, but I see a patient in clinic and I map them with ultrasound at the same time as that clinic visit. So you have to think about where your referrals come from and who you are as an interventionalist. If you're an interventional radiologist, you are not naturally within the access site creation algorithm that exists. So you need to insert yourself in the least invasive way possible. So we met with our nephrologist and said, listen, we're happy to see these patients, map them. And if they're surgical candidates, send them on their way. They have to get their mapping anyway. And I can read their mapping and counsel them on their options at that same time. And I don't create any extra work for the patient, no extra appointments, which plays into the not the best step follow-up for these patients. So that's, I think, really important to establishing a practice. You have to make it as easy as possible for the patients. So I map them with ultrasound and I review that mapping at the time of clinic visit, talk to them about surgical options, percutaneous options. And I typically, if they're not a percutaneous AVF candidate, refer them to the surgeon of choice for the nephrologist. And that helps keep the nephrologist happy.
Okay. What sort of reception have you gotten from vascular surgery? Has it been collegial? Does it feel like, feel like you're stepping on their toes? How has that algorithm kind of developed since you started a year or more ago?
So it really hasn't made any waves here yet, which is great. And we've tried to be very delicate about our approach to it. We're not stealing patients. And they are quite busy in other areas as well. So just to emphasize, this procedure is being done by interventional radiologists, interventional nephrologists, and vascular surgeons. So whatever your practice is, obviously interventional radiologists are probably the primary audience tonight, but is going to affect how you approach the situation. So our vascular surgeons haven't really complained to us at the moment, and ultimately I'm trying to establish a working relationship with one of the newer vascular surgeons who's has more time in their schedule to take patients and to become involved in a multidisciplinary approach. And our goal is to work down that line and establish. We already have a multidisciplinary conference with the nephrologists to talk about dialysis access and review fistulograms. So we'd like to kind of expand that to include discussion of patients' access and their options in advance of the fistulogram. So we'd like to bring them in on that side.
Okay. What do you think about the potential for immediate deep venous coiling with the ellipsis placement, recognizing that you'd need fluoro at that point? And then a second question: how have the patients reported their experience with dialysis centers that are unfamiliar with this type of an access? So have they had any issues when they show up with something like this when the nurses are going to access it?
Right. So as far as the brachial coiling, if you see that, going back to the secondary interventions that were needed for ellipsis patients, actually branch vein coiling was not the most common procedure that was needed for facilitation of maturation. It's actually angioplasty and thrombectomy. So I don't think that there's a strong need to coil the deep venous system at the time of the incident procedure. That's not necessarily true for Wavelength. And occasionally I've had to coil the second brachial vein to further facilitate diversion of flow. And that's something we'll see if that really causes problems down the line, but it hasn't caused immediate problems, and others have done it as well. And I would argue that fluoro would be nice for coil placement, but it's not 100% necessary for coil placement in the brachial vein, especially if your ultrasound technique is appropriate and you can do compression of the vein and coil under ultrasound for the more people who are more comfortable with that. As far as cannulation side, so cannulation for me has been one of the biggest eye-opening things. And this is where BARD and Ellipsis were disparate up until probably now. So Ellipsis was owned by Avenue Medical, which is a smaller company, but just recently got bought by Medtronic, whereas Wavelength has been developed and rolled out under a larger company, Becton Dickinson. And in having the resources of that larger company, it's allowed them to provide a lot more support around the device than Ellipsis has been able to provide up to this point. So Wavelength, when you bring the device into your center, it comes with ultrasound training of your ultrasound department, however many times you need it. You get hands-on training for the physician performing the procedure. You get assigned a representative and a clinical specialist to attend any and all cases, minimum of 5, but I actually continue to have the clinical specialist there because I find, and the rep there because I find their help invaluable. And additionally, that clinical specialist is going to follow the patient to the dialysis center. And the initial thought was that we'd go to the dialysis center, train the dialysis center in the access, because you just have those 2 little needle marks on the arm. So dialysis centers are used to looking at all the scars and trying to figure out where the fistula is. When there are no scars, it becomes very difficult with a softer fistula, like the percutaneous ones, to figure out where the access sites need to be. So once they become a little bit more familiar with the anatomy, with where they're looking for access, I think they'll be more comfortable with it. But every patient is different too. Some's gonna have cephalic outflow, some will have split, some will have basilic. And having the clinical specialist there with knowledge about that specific patient for initial access is really helpful. I've seen some colleagues online say that they've had the patient record a successful access on their phone so that they can then show it to people. And that's a fantastic idea. But I found that the dialysis cannulation, they struggle a little more with access of these softer fistulas. And I don't think that's prohibitive to the technology being successful. I think that's a red flag that we really need to focus in on education and training and support of the dialysis centers to help encourage and increase the successes of cannulation. And I honestly think we'll see an increase in successful surgical fistula cannulation as well if we do that.
Do you get, Allison, this is Stephen, do you get from the surgeons, as you showed in that one slide where you showed the additional accesses that you're providing in the forearm, the concern that, perhaps you've done a mapping, you see that the distal forearm is, diminutive, and so that you might move up to more proximal forearm and therefore move up to percutaneous approach. Do you get from them though that they're concerned that if that failed, that the upper arm would be in jeopardy in terms of maybe they worry about there being an increased rate of steel, given that they've had a prior, things like that? So do you get any of that kind of pushback from them that they're afraid that what you're doing may compromise an upper arm access?
I have not personally, and I don't think it would. These can be taken down. And if I were to take one down, I'd probably put a little stent in the vein to just close it off. But one thing is that oftentimes, even if you don't get full maturation or you're not able to successfully cannulate and they need to move to a surgical fistula, that forearm fistula has increased the flow in the outflow vessels somewhat and can potentially increase their size and make a surgical fistula in the upper arm more successful. In terms of increasing steel, the lower flow volumes in this fistula, I haven't seen too much steel in issues. I think there was one reported in one of the papers as a complication, but the steel rates are lower in percutaneous AVFs than they are in surgical fistulas, especially upper arm fistulas when you're tapping into the brachial artery. So I haven't seen it be an issue or heard any complaints.
And do you use any kind of temporary tattoos for laying out the anatomy for first-time dialysis, or has it just been using the folks from the company to go to dialysis with them?
Generally the clinical specialist, but it wouldn't necessarily be a bad idea. And alongside, videoing successful cannulation, marking access sites and taking a picture and having that patient take that picture to the dialysis center and keep it on their phone would be wise.
Yeah, I can envision a patent on a temporary henna tattoo.
I see the wheels turning in your head as you speak.
Allison, I just had one other question. In your personal experience, the successes, the ones that mature, how many procedures have the patients had to have to get to maturation? Have most of them been like a one and done? And then on the counterpoint, the ones that do not get to maturation, what's been the typical cause in your experience? Has it been too many collaterals that can't be controlled, the higher flow rates into the deeper system, or just the anastomosis is just not giving good flow rates?
Mm-hmm. So most of my fistulas are ulnar in the forearm. The ulnar veins just tend to be enormous in most patients. Most secondary procedures, the majority of the secondary procedures I've had to do have been branch vein coiling, and it's typically the brachial. It's not been more than 50%, but it's been maybe 30%. And I often see successful maturation after that. What I do see sometimes is initial cephalic maturation on the 2-week follow-up. And then at 4 weeks, I see the basilic starting to subflow, because the basilic vein also typically has a very large communicating vein with the proximal brachial vein. And so I think as the veins mature and dilate, we start to get decreased resistance to flow on the basilic. But actually, I've heard that a lot of people have the opposite. They have more cephalic maturation. So sometimes that's a pretty simple fix. You can just ligate the median cubital, and then that flow will go out the cephalic. So that's where as an interventional radiologist, having a surgeon that you work closely with who understands the anatomy and who's willing to help out with that. Although I have thought about doing my own median cubital ligation, I think that would probably be pretty simple from an IR standpoint with ultrasound and like a little tunneling device. So that's a pretty quick fix. The anastomoses themselves for Wavelength, and that's what I can speak to, tend to stay widely patent. I haven't had an issue yet where one has thrombosed off, although I hear the proximal radial arteries tend to have a little bit more of an issue with perianastomotic stenosis of the outflow vein for whatever reason, similar to the ellipsis devices. And I say, there was another part of your question. So oftentimes if they need secondary procedures, it's one procedure that facilitates maturation. When you start getting to needing 2 incident procedures, your rate of success starts to decline significantly. And it's really a discussion with the patient, setting expectations. Are they pre-dialysis? Are they on dialysis? How quickly do you need to get this thing functioning? I had a patient who had a radiocephalic that she was able to use for a while, but she never fully matured, which was kind of a red flag there. But we tried it, and we had to take off one of the branch vessels, and we got some more flow, but we just couldn't get it to where it needed. It kind of plateaued out around 400. And finally we were like, let's just stop messing around. We could probably do more, but let's just get you a functioning access. So she went on to the next, but she also had we've been finding over time that, from what I hear from other people who use it, a tortuous perforator is less likely to mature, or is going to be tougher to mature than a straight perforator. And you'll see all sorts of perforator configurations in patients. They can be U-shaped, they can be duplicated, they can join quite low down in the forearm, which isn't necessarily prohibitive, but with lower flows, you may have trouble getting the flow volumes you need through that. So the mapping is really important in those situations.
Okay. Again, that was a great discussion. Appreciate the questions that came in as well. If there's no other comments, again, thanks, Allison, for doing this evening, for putting this together. I hope everybody has a good holiday break. Our next webinar is going to be in January. It's going to be the 12th of January with Sandeep Bagla. He's going to be speaking on genicular artery embolization. So that'll be our next talk. Again, have a happy and safe holiday, and good night, everyone.
Thank you.
Thanks a lot for tuning in, guys.